Good morning. Welcome to this edition of Your Health Matters. My colleague Pat Williams couldn't be with us this morning. We miss him, but he'll be back next week. Today we have with us Dr. Rudolfo Benatti, who is a cardiologist with University Hospitals. More and more people in town are getting to know Dr. Benatti. He does cardiology care both here at Conneaut on Mondays and Wednesdays, and he sees patients in Geneva also. And if a patient comes into the hospital and needs to have a cardiologist consult on the case while they're in the hospital, Dr. Benatti will do that, which has been a very big step forward for us here at UH Conneaut, and we're very, very pleased that Dr. Benatti joined the staff here. So we have some issues in cardiac care that we're going to talk about. Dr. Benatti has a couple of things he wants to cover. I've had questions from folks to direct his way, and hopefully we'll be able to come up with some things this morning that you folks will find useful. Dr. Benatti, my understanding is that heart disease is still the #1 killer in the United States. Is that true?
Yeah, it is the #1 cause of deaths in the United States. The second one is cancer.
And heart disease is still first, both for men and women.
Yes, and actually there was a downtrend. I mean, the cardiac disease a few years ago, it seemed that there was a problem that with all the advances that we'll be able to improve the patient's outcomes, but we still have a long way to go. And I think in part is the reason is we're very good today at taking care of very sick patients in the hospitals that had heart attacks, but unfortunately we still have a long way to go in terms of prevention. Prevention, I think it's the big gap. We have newer medications, we have statins, we have stents, we can do surgeries, but in the end, if we can't prevent, we can change the behavior of the patients and lead them to a healthier lifestyle. We're still going to see plenty of heart disease in our communities.
This is really important. Sure, I mean, we're getting better and better on the back end once somebody's already in trouble. But gosh, that's never as desirable as avoiding the trouble in the first place. Now, I know that there's a tremendous amount of research in this area in terms of identifying what risk factors are, things that people can do differently to lower their risk of heart disease. Let me ask you, do you feel that these things that people can do you feel that if they actually do them, that they actually will lower their risk of heart disease?
Yes, it is.
I mean, clearly, no question, it will help.
There's no question. There's solid data from studies that show that, for instance, smoking is probably the single most important cause of coronary artery disease, of heart attacks, and also of strokes. And there's studies from England that show that they look the trend of what happened in terms of heart attacks in England, and there was a drop since the 70s. And the single most important thing that happened was that the percentage of the population that was smoking dropped. And we know that if a patient who currently smokes and he's been smoking for 30 years, and I see that all the time in my office, and I say, oh, I've been smoking for 30 years, I know that I'm at a higher risk of having a heart attack than somebody who hasn't smoked. So I don't feel that now I need to do anything. But that's wrong. We know that in a year after quitting smoking, they're reducing about 50% 50% the chances of having a heart attack. So they still have a higher risk than somebody who never smoked, but their risk of having a heart attack significantly drops within 1 year after quitting smoking. So
50%?
Yeah.
50%? In other words, you cut your risk in half.
In half just by quitting smoking.
Even if you smoke for all those years,
yeah,
you still, within a year of quitting, you will cut your risk in half.
Yeah.
Wow. See, the general public, I don't think, we see a certain view of the country and of people and so on because of what we do. We know how common heart disease is.
Yes.
And we know how devastating it can be. And strokes too, of course. Gosh, I mean, but anything that has to do with the arteries, we're particularly talking about the heart arteries today. We know how many people have this, and we know what the consequences of it are. Everybody out there knows that quitting smoking is extremely difficult. I mean, we're not going to, we're not going to dance around about that. It's tough. It's an extremely tough thing to do. And there's help. There's different things that can be done to help, and your doctor can help you with that. But the point is that it can be done. And if you see somebody have a heart attack, if you actually see somebody have a heart attack, and you see what they were like before they had the heart attack, and then you see what they're like if they've knocked off 40% of their myocardium, their heart muscle, and you see what their quality of life is afterwards, and you realize what you're doing can really place you at risk for that, that will help you to really think clearly about it and really understand what you're looking at. That can help you.
Yeah. Unfortunately, I have a few patients, I would say plenty of patients, that unfortunately they just come to that conclusion and after the heart attack. After the heart attack. And that's a problem because now you have a heart that lost some of its capacity, of its function, because a piece of it died during the heart attack. I mean, we try to do our best. It is still, I think, one of those things that even I'm a cardiologist, and sometimes my clinic is busy, and I imagine that same thing happens to primary care physicians. But I think it's one of the things that we probably should be, we the medical community should be probably doing a better job in not only teaching. I think everybody knows that smoking is bad, but sometimes I do feel that the patients, okay, I have to stop, but there is the next step. I mean, how do I do that? What are the strategies I can do? What are my options in terms of medication? I think we still have to do a better job in trying to help the patients. I think it's a lot on us, on the medical community, more than the patients. But yeah, we have some antidepressants. We have Chantix, which is a medication that I've been using. There's some side effects, but a few patients actually they do pretty good with the drug, and they've been telling me that they're quitting. And I'm having some good results with that option.
That's great.
There are the patches, the nicotine patches, and then there are always other strategies that we can discuss, more behavioral strategies in terms of dealing with the urge, with the anxiety between the cigarettes, cutting down caffeine. So there is a bunch of things that we can do to try to help our patients.
Now let's say that there's somebody listening out there right now who hears this, and they would like to talk to you about it.
Yeah.
They would like to call you and come in and talk to you about quitting smoking. I mean, is that something that you'd be open to?
Yeah, sure. I think as a cardiologist, I think and as I said, it's a big risk factor for problems that I'm gonna they're gonna have to deal with if they don't do something. Now, I'll be more than willing to discuss that with any patient. As I think the primary cares and the pulmonary medicine doctors, I mean, they will.
Sure, they all will, but you know, I just know kind of how things work, and sometimes, you know, people will be hearing you and they'll say, gosh, this guy really knows what he's doing, he seems like a nice guy, maybe I can go and talk to him. And so, you know, Matthew, the number is going to be showing, Dr. Benatti's number is going to be showing. So folks, you see Dr. Benatti's number going across the screen, and what he's telling us is that you can call and go in and see him, and he will help you to quit smoking. This is a very, very serious thing. You know, in terms of doing something for yourself, but also in terms of doing something for your family. You know,
yes.
You know, all the people that love you, they don't want you to have a heart attack.
Yeah.
You know, so Dr. Benatti will help you with that. I had been asked, and I would like to hear what you have to say about it, is there any advantage at all to the electronic cigarettes?
So that's an unknown yet. I mean, there are some. So the electronic cigarettes is a way. So the big problem that causes the addiction is the nicotine. But the nicotine is not the real problem with the tobacco. Is all the other things that you inhale and then end up in your circulation, and then that damage the blood vessels. So in theory, the electronic cigarettes will be a way just to deliver the nicotine that is the addicting substance in the cigarettes, and you wouldn't be exposed to all the other junk, let me say that word, but junk that comes with a cigarette. The problem is that there are no studies that show that this is a reasonable alternative, and we don't know the impact of the electronic cigarettes. We don't know what other substances are there. Actually, there is. I saw on a medical news website a few months ago that there was a study from England that measured a substance that is associated with cancer, and they saw that the concentration in the vapor in the electronic cigarettes was actually 7 times higher than the concentration of the same substance in a normal cigarette. And so we don't know. I mean, if we're really helping, if the electronic cigarette is a viable, reasonable option.
I would have to imagine that there are some well-designed studies in progress to measure that.
I mean, I don't know. I mean, it have to be something done by the NIH, and right now I have no clue if that's being.
I don't either. I don't know. The thing of it is, these things that sound like good ideas, good ideas come along all the time. But what we have to know is what actually happens, what the results actually are, and they have to be results that are reproducible. I mean,
yeah.
You know, that's why medical research is designed so carefully to eliminate bias and to eliminate chance, and to make it so that when we tell patients something, we're basing it on information that has been tested thoroughly, that's been reviewed, and that is reproducible from patient to patient and from place to place. Otherwise, you're really not sure what you got. You know, it's kind of speculation. And it sounds like electronic cigarettes are in that class right now. We really are not sure. That study that you mentioned that shows that a certain carcinogen is 7 times more present in the vapor of electronics. Well, that's not too happy. I mean, that's not necessarily good news for electronic cigarettes. So I think that at this point we have to say that it's probably a false sense of security. We really don't know.
Yeah, I still think that the best option first option is to quit completely the cigarette. I mean, it would be the best right now, the best alternative. And
Well, folks, we've been talking about how heart disease is still the #1 killer, males and females in the United States. And we've been talking about where the focus really needs to be is preventing the heart attack in the first place. And Dr. Benatti has pointed out that the best thing that anyone can do is to quit smoking. Are there any other things that people can do?
There are several other things. I think I mentioned smoking initially because that's the one that we know that the impact is huge. But diet, exercises, weight loss, I mean, those are things that I see all the time coming to my clinic, patients that had stents, surgery, and they're still inactive. They follow a bad diet. Unfortunately, I do understand that unfortunately in the U.S. it's cheaper to eat a Hershey's chocolate bar than following a health diet. That's those are one of the things that the society has to decide. I mean, if we're going to really tackle the issue of heart disease, how do we ensure that everybody, not only rich people, but everybody, even people that struggle to pay their bills, that live on, that they have Medicaid, they have Medicare, that they're actually going to have access to healthy foods, that they're not going to be eating processed meat and frozen food that they buy at Walmart. They're going to be able to buy fresh vegetables, lean meat, like fish and chicken, follow a low-salt diet. So that's something that the society as a whole has to, okay, I mean, we need to change something, because it's easy for me to say, I try to follow a healthy diet, I exercise, I go to the gym 3 times, 4 times a week, I try to run, but I mean, it's different than somebody who can't afford a gym and who can't afford to buy healthy foods. But I think exercise and diet, controlling the weight, those are very important things.
People can exercise. I mean, it takes a decision to do it, and it's like anything else. Once you form the habit of it, it's easier than before you have the habit of it. But that is something that is under people's control.
Yeah. Yes. Sure. I think I mean, of course now winter, but during spring and summer, I mean, you have. I mean, all you have to do is put a pair of sneakers and you can go and walk for 30 minutes 4 times a week. That's what the American Heart Association recommends. 2 hours of light aerobic activity a week. That is important. Everybody should do that. There's no question. I mean, it's something that everybody.
Absolutely. This is something that's been mentioned on this show several times previously, but here you hear it from an expert, folks. That exercise, walking, a nice brisk walk. I mean, you don't have to go crazy, but just a nice walk for 30 minutes, 4 times a week, is something that is good for your heart. Yeah,
and it's good for all the circulatory system in the body. It's going to help you if you're trying to lose weight. You have to exercise to make your body spend more calories. So it's going to help you lose your weight. It has an impact in the blood pressure also, as following a low-salt diet has. So and we even for patients with bad heart disease, or patients with we're expert on congestive heart failure, we want our patients to be active. We don't want our patients to be rested and losing all the muscle in the legs. I mean, we want them active, because the more fit they are, the better they're going to feel actually.
Now, I had questions. People are saying that regarding blood pressure, well, what is the number, and if I'm above that, I've got high blood pressure, and that's changed for people who are over 50 or over 60, or no, it hasn't, et cetera. Could you bring some clarity to where people's blood pressure should be?
So that changes all the time. There's it's all based on the guidelines, and then the guidelines are basically a bunch of people that are deemed experts, and they are experts in a certain subject. They get together and they come up with, oh, what is the goal for the population? What is the goal for that patient based on its the risk profile? So the latest recommendation from what we call the Joint Commission. The goal is that the blood pressure for somebody who doesn't have other risk factors, who has no diabetes, who has no the issues, had no heart attack in the past, doesn't have a heart problem, it's a blood pressure of 140 over 90 would be the upper limit. Would be the upper limit. But of course, between 130 and 140, you already start to, we call that in the pre-hypertension range. You already start to tell the patients, hey, if the weight is above the target, you say we need to lose some weight, try to follow low-salt diet, and if it's above 140 over 90, persistently, despite all the interventions, weight loss, exercise, then you have to introduce a medication. Then for other patients with diabetes, patients that have kidney problems, then they usually, or had heart problems in the past, then you have to lower this upper limit. You want a blood pressure in the range of 120 by 80. There was recently a very important study that was published in the most important journal of medicine last year, called the New England Journal of Medicine, that looked into blood pressure goals for older patients, because that's something that it's a gray zone. Nobody knows what to do with 80 years old, 70 years old. What do you do with those patients? And we also know that keeping the blood pressure lower in the 120 over 80 range, it's important for them. It decreases the number of patients that come to the hospital with congestive heart failure, which is with heart attack is a big deal. It's something that most people don't understand, but congestive heart failure is the single from all the disease that the Medicare, Medicaid spends, congestive heart failure beats everything. We spend more treating congestive heart failure than any type of cancer.
Wow.
So if we are able to, even the older population, keep the blood pressure under control, we're making sure that fewer people will be coming to the hospital with congestive heart failure. And congestive heart failure is basically when the pressure on the heart is a situation that the heart is struggling to pump blood, and that causes fluid to accumulate in the lungs, and the patients come usually to the emergency with shortness of breath. And then we'll auscultate the lungs, we can hear that there is fluid in the lungs, we get an x-ray, we see fluids in the lungs, and then we'll have to bring the patients to the hospital, get those fluids out using some medications, and control the blood pressure. So these admissions for congestive heart failure, they're like the single most important thing that we have to tackle if we want to make sure that we're spending less with health in this country. That's one of the big issues right now.
And what that translates to, folks, is that it's very, very common.
Yeah.
Which means that a lot of people who are hearing us right now either have been through this themselves, know somebody who has been through this themselves, or will go through it.
Yeah.
I mean, it's very, very common. It's common enough so that we have to take it seriously for ourselves.
Yeah.
It's not something that's going to happen to that person over there but not happen to us. There's a pretty good chance it will happen to us unless we do something to prevent it. So, that's why, we're covering these issues, is because it really does apply to folks out there, and all of us, actually. And these are the kinds of experiences that you really, boy, if you get a chance to avoid them, you really want to avoid them, because they're extremely unpleasant to go through something like this. And dangerous, of course. Okay, well, so keeping track of your blood pressure is just a smart thing to do. And your primary care doctor can help you with that in terms of things you can do to help control your blood pressure. And they will monitor your blood pressure. And if despite everything that you're doing, it's still up in a range where it's going to cause you problems, they can get you on the appropriate medications. Dr. Benatti certainly does this all the time. I mean, he deals with blood pressure all the time. It's one of the big risk factors for heart disease.
Yes.
So, he's also somebody who can help if you have other questions, or you want to get his opinion. You can talk to him about blood pressure too.
Yeah. The other thing I want to mention about the blood pressure, two things I want to mention about blood pressure management. One is the low salt diet. So that's something very hard to explain, because the way the American Heart Association tells us is patients should be below 1,500 milligrams of sodium a day, and then that's how do you measure that? That's less than a teaspoon. And sodium, basically, it's a salt. So 1,500 milligrams of sodium a day, you can't really, it's hard to understand that. What I usually say to the patients is try to stay away from processed food. So anything that comes inside a bag or package, or it's frozen, or it's something ready for the microwave oven, or it's processed food that there's sodium there, because it's one of the ways to enhance the taste, or to keep it preserved for longer. So every time you buy something that comes inside a box, there is salt in there. There's no way. You just really see, you can see the labels. Then something that people don't pay attention to is that soft drinks. Say, oh, I drink Coke Zero or Diet Pepsi, and there's no sugar, so it's not bad for me. And there is salt. There is salt in there, and it might be cutting salt from the rest, but if you're still drinking pop frequently, they're still ingesting salt. So also water is much healthier. There's no calories. It's going to help your kidneys work well. So just stick with water, but cut down soft drinks. And the ideal diet, as I said, you're going to eat your vegetables, fruits, grains. They're a good source of sugar, grains, and lean meat. And you're going to season. You can season with whatever you want, but you're going to use very minimal amount of salt.
Well, there are seasonings out there that are really tasty, that are designed specifically to address this problem.
Yeah.
Where you can get flavor, so nice flavor,
without adding salt.
Without adding the salt.
Yeah. So that's what I try to say to patients. I think that there is not I don't give this is how you're gonna eat, but I just say, like, stay away from processed stuff, including stay away from soft drinks as much as you can. Use the minimum amount of salt as possible and try to use fresh ingredients. If you do that, you're probably gonna follow a low salt diet. The second thing about hypertension is that there's something that I see a lot in my clinic, and is associated with weight. It's called obstructive sleep apnea, and it's one of the causes of elevated blood pressure that doesn't improve despite multiple medications. So I see a lot of patients referred from primary care, patients that are obese, and they're taking 3 medications, and the blood pressure is still elevated. It's 150, 160, the top number. And when we talk to them, how is their sleep quality? They usually complain of poor sleep quality. They wake up tired in the morning. They feel fatigued during the day, no energy. They take naps. Sometimes you're talking to them during the visit, and then they take naps in front of you, and then we're sending those patients to Geneva Lodge. There is a couple rooms there that we're doing sleep studies. Dr. Barron is the pulmonary doctor that reads this test. So we basically have the patient sleep one night with a bunch of wires around the head and the chest, and then to confirm whether the patients have sleep apnea or not. And then every time I see, I'm surprised, because I think I can count the times I sent somebody for a sleep study and it was normal. Almost everybody that we end up sending, they come with this complaint. We find out they have sleep apnea, and then the treatment would be to either lose weight or to use a mask, the CPAP. And then we have great responses. The blood pressure improves significantly.
So the blood pressure responds to that.
Yeah.
Once they're treated appropriately for the.
And that helps. That's the most important thing. If you lower the blood pressure, you're reducing the risk of heart problems.
It's very, very good that has come up in this discussion, that connection gets made, that there is a connection between getting tired during the day, maybe sleep apnea, and heart disease.
Yes.
And it's easy enough to test for sleep apnea. We encounter it all the time. Just like doctor says, it is very hard on you if you have that. And not to mention the impact on people's quality of life. So, don't be shy about bringing this up with your primary care physician. If you feel like, gosh, I just got tired, I have no energy, and because if you have sleep apnea, you can't really diagnose it yourself. You're not really aware of it, but you can suspect it. You can talk about this with your primary care doctor and just ask the question, do I need a sleep study?
Yeah.
Maybe I need a sleep study. Maybe, particularly if you're having trouble with your blood pressure. So you don't have to wait for somebody to ask you about it. You can ask somebody about it, because if it is going on, it can be fixed. There's good treatments for it, and the sooner you catch it, the less damage you're going to do to yourself. So it's much more widespread than people think. It's certainly more widespread than, as doctors we realized. It's very widespread. So it is definitely something for you folks to keep in mind when you talk to your doctors.
Yeah. Usually the patients that have that, they don't really notice. They just have they have the symptoms. They're tired, but usually it's either the wife. Most times it's the wife, because I see mostly men. So it's the wife that notice. First, she complains that he snores a lot. The patient snores a lot, but also sometimes they notice that the moments that there is apnea, that the person that has trouble breathing, that is like choking, and then she can feel that the body is trying to do a lot of generate a lot of pressure to help breathe in. And so it's sometimes it's scary. I had a colleague who I used to do night shifts and a long time ago in the ICU when we were fellows, and it was basically, the impression was that he was choking, like he was getting. It's really scary sometimes, and I felt like I wanted to wake him up and shake him, so he could breathe. But eventually, he starts breathing again. And if that happens with a lot of frequency, that it puts a lot of stress in the body, and that releases a bunch of hormones that will in the end increase the blood pressure, and the blood pressure will eventually lead to all the problems that we already discussed. So I think it's something that also goes a lot unrecognized, but I see more and more, the primary care physicians are catching that sooner. I still catch sometimes in my clinic that it was missed before, But I think it's something that everybody is starting to recognize sooner.
Excellent. That's excellent. Well, there are some other things to cover which perhaps we can do on our next segment. We would like to have you come back if you would.
Sure.
I'll be in touch with you, and we'll set up a date where you can come back and talk to us. There's several more issues. You have a question? Matthew has a question.
Does alcohol play a role in high blood pressure or heart disease?
Yes, I mean alcohol. I mean it's another risk factor for elevated. It can elevate blood pressure. We usually tell the patients to cut down. I mean it's hard for some patients, but you do have to decrease the amount of alcohol, the alcohol intake. There is a recommendation that if the patient is already drinks wine, like especially the red wine, 1 or 2 cups a day, you shouldn't discourage the patient to keep doing that, because we think that red wine has some benefits in terms of cardiovascular risk. People in Europe, they drink a lot of wine and they have a lower risk of heart attacks compared to us. But I usually don't try to. The last thing we want to do is stimulate them to start drinking if they were not drinking. But you do want, in general, to cut down alcohol. That has an impact in blood pressure. That also we know the alcohol can damage the heart. I've seen patients with dilated hearts, very weak hearts, because of excessive alcohol intake chronically. So that does also cause heart problems. So in general, alcohol, we're all humans, so drinking a little bit in parties or weekends, not a lot, that's okay. But daily alcohol, it's bad. It's bad for the blood pressure, it's bad for the heart also.
Yeah, and from my side of the street, it's well established the relationship between alcohol and liver problems, alcohol and pancreas
problems. Yeah.
So it's just and it's a neurotoxin. So I mean,
Yeah.
it's like in moderation. Like he says.
Occasionally, yeah. We're all humans.
Sure.
I drink a little bit sometimes,
Sure,
but
sure.
The daily I wouldn't, and large amounts never. Daily also I don't recommend.
Very good. Very good. Okay, well, we'd like to thank you very much for taking the time to join us today.
Thank
It's
you.
very kind of you to talk to all of us here, and we'll be in touch about having you back where we can cover some more of the topics in this extremely important area. Thank you very much, Dr.
Thank you for having me here.
And we'll see you next time on Your Health Matters.